completeness of registration of deaths is above 95% in Sri Lanka, but the issue is with the quality of the cause of death rate.
About 52% of the deaths are being declared in the hospitals, about 42% in the field. Therefore, quality may vary. That is why that was the biggest challenge in Sri Lanka.
Globally, if you take any health system, they are facing challenges with limited financing. So prioritization plays an important role. As a planner, it's important for us to know the real cause of death, basically to allocate the resources and develop the health institutions appropriately.
In the hospitals, that is been declared by a medical officer. In the field, it is written by a non-medical person. Although we really appreciate their efforts in the field, but obviously there's a difference because a medical officer can analyze and understand well medical terms and everything as per the ICD code they can declare, but in the field it's not happening naturally. So there's a discrepancy between two.
And that was why we agreed in the work plan to really focus on quality, because death and birth are being well recorded.
I can give an example. When my father died in 1998, he had an established liver cancer and it was diagnosed, and I was told that he had some shortness of breathing before his death. So when the coroner came to the house to give the cause of death, finally he had shortness of breathing. Rather than giving liver cancer, he gave some other cause of death. 48% of the deaths occur in hospital, home, that is in field. We have started phase 1 in 5 districts, Jaffna, Kilinochchi, Kurunagala, Mahathale and Kalambu districts. We have started the verbal autopsy and we have got the list of the death registration from the Registrar General's office, and we involved additional Registrar Generals also. They helped us giving the details who have died. So in Sri Lanka, the midwives, they are in the field, so it's easy for them. So it's very less work for them. You see, for 3 months they have to go. They would do only 5 verbal autopsies approximately, average. So they did with enthusiasm and with so much of interest. We collected about 2,000 verbal autopsies so far. We noticed that 22% of deaths due to stroke, which we are not aware of that.
Why we selected a public health midwife was that this interview has to be done with caretaker of or the close relative of the deceased person. So in our domiciliary healthcare model of the public health midwife, is almost every house is registered with the midwife. They are known to the community. They are confident with the midwife to disclose any symptoms and signs. So by employing the midwife to do the interview, we thought she would visit the household at a time convenient to the respondent. There are so many innovative things that the midwives have done during this process. In addition to what we recommended, they have used their mother support groups. The mother support groups are established in her area, so they have got the help of these mothers to find out about the households where the deaths have occurred.
I was really delighted to see how well the verbal autopsy tool worked in Sri Lanka. We had not used it before there, so we were not sure that it was culturally acceptable, but we have had very little refusal rate, actually none, as far as I know. So for me that was really important, and the result that you get from a VA is totally dependent on the interview, and therefore having the right interviewer is critical, but of course also having the family member who looked after the person who died. So the two things, if you don't have them right, you don't get a cause of death, which is worthwhile having.
We are not asking the midwives to interview deaths that were referred to the coroner, the police or the magistrate. So these deaths are usually registered in Sri Lanka with the Grama Niladhari. So they get the list from the Grama Niladhari and then they visit the household through an appointment and then do the interview. Grama Niladhari is like the local or the village level, the grassroots level administrative officer appointed by the government. Another challenge at the beginning was whether the midwife would be capable of handling the tablet and the IT technology. So there was a special 4-day training. In addition to the technical aspects of verbal autopsy, we gave a 1-day special training for them to use the tablet for this purpose. It was really interesting to see that the midwives learned the technique, the IT aspect very quickly. In the MOH area, we selected the whole staff of midwives, which range from, I would say, very young midwives to those who are about to retire, but still after the end of the 4-day training, they were able to learn the IT aspect of saving, uploading and editing the data entered in the tablet.
In the Bloomberg program, we have fellows who have come to Melbourne and we have worked with them for 3 months. And that has really been useful for them and we feel we are leaving something behind to the country.
I would like to say that we were able to train in-country experts. If we take an example, for verbal autopsy, we have trained 3 medical officers. They know how to do the training to the midwives, and 2 of the medical officers maintain the server, and now they know how to do the data cleaning, data analysis. So when the country wants to take it forward, the capacity is there.